Okay, should we just...
Okay,
Can
I'm gonna
you
stay.
see my
Excuse me.
slide? That's the
I'm
most
gonna
important.
stay on in case there's any problems, okay?
Thank you very much. Can we maybe just start by saying welcome to everybody? A few have joined us after we made a few comments. We are a couple of minutes after, but we are going to have two cases. One by AAST, who is represented then by Tim Hardcastle from Durban in South Africa. And one after that is going to be presented by Victor Hugo Chao from Panama. And our panelist tonight is Amber Himmler from Harbor UCLA Medical Center in the United States, Christina Ray Ralcarel, who is from Hospital General Universitario Gregorio Maranon in Madrid, Spain, and Simon Robertson. I have to say he's an anesthetist because I was told by Jose and Antonio that there has not been an anesthetist on the call, and I said it's just about time. He is consultant anesthetist in Canberra in Australia, originally from South Africa though, and very surgical. And together with me, we are moderating Marianne Wright from Brazil and myself from Norway, Oslo. And then I think we'll just leave the word to Tim to start the discussions, and we'll try to stick to time so we have approximately a little bit less than half an hour for each case. We are going to, and I was told to say also that that any comments, because we have there is an agreement with the TACO, the journal, and about the best case is going to be selected. The best case every quarter is being selected for publication. And if there are, so the comments that are being made about the discussion, if people are willing to actually have their comments in or comments to that case presentation when it's being published, it's just to have that in mind when we're doing this. Tim, get on with it.
Thank you, Tina. Right. So I have built in a couple of breaks where I will allow the panelists to comment. So our case is a gentleman by the name of Mr. K.M. He's a 35-year-old male who was a pedestrian vehicle collision hit by a truck while he was crossing the road. He was admitted to a tertiary level 2 trauma center who have surgeons, CT, occupant, OR, etc., and initially assessed there. His ATLS primary survey showed a clear airway, decreased breathing on the left with a decreased air entry, some mild respiratory distress, but not to the point of being hemodynamically or cardiovascularly unstable. GCS was 15 out of 15, and he had a bit of abdominal tenderness noted, probably more over the left than over the right side of the abdomen, as well as a grade 2 open femur fracture, but pulses were intact. There's his chest x-ray that was done in the emergency department of the other hospital. Question number 1 for the panel. What would you do now before I tell you what we did and why?
Can we just make the rule that the panelists are first, they are allowed to comment, and then I think since we're only 23 people present, I think anyone who is present is allowed to put their hands up and also have questions or come up with comments if they want to. So, panel.
I'll go back to the slide.
So who's going to do what?
Okay.
Christina.
So should I start? So it seems like we can have an injury in the diaphragm and we have a diaphragmatic hernia. It seems that it doesn't make any respiratory compromise for now. So maybe if he remains stable, we can go to the CT scan and preparing the OR. If vitals are okay for now, I don't I don't need to put a chest drain for now, but also I can prepare it just in case something is happening. But we will have a little mesh if we put drain chest just without thinking on it.
Stephen, I think you had your hand up.
Yes, this is the exception that proves the rule. Normally, I don't rush to do a chest X-ray, but based on physical exam and even on the EFAST, you wouldn't see sliding on the left side. You hear no breath sound, so you would just say, just go ahead and put a chest tube in on the left side. But in this case, the patient was totally stable, and I think doing a chest X-ray was a good thing to do. So you can see a diaphragmatic hernia. And the chest tube in this case would be contraindicated because you would just have to hook it up as a colostomy, likely to perforate the colon. So, I agree that the patient would just go to the OR for a laparotomy in this case.
The rest of the any other comments from? Can you go back one slide, Tim? Anyone?
Yeah, I was going to say the same thing I think ATLS really emphasizes not hearing breath sounds and putting a chest tube in, and this definitely is the exception there. I know you said the patient had abdominal tenderness. The patient was not peritonitic?
No, just mild, more left upper quadrant tenderness than anything else.
Simon, can I ask you something?
Of course.
Does this worry you?
It does. It surprises me a little bit, I have to say. The people I've seen with diaphragmatic hernia are a lot sicker than this gentleman. So I'm a little bit surprised. But the concern really occurs at the time in which you induce positive pressure ventilation and so on. And I wonder, and this just might be that you've got me here as an anesthetist because I want to be the chicken, right? So the chicken in me wants to run this patient through the CT scan. In a way, you could argue that this is a form of distracting injury. It's obviously going to need a laparotomy. He's obviously going to need his diaphragm repaired. There's no way he's not going to theatre. But we know he's got a broken femur. Why don't we have a look at what his pelvis is doing as well? Let's plan out how to get our orthopods in after his diaphragm's been repaired and sorted and so on and so forth. I think it's reasonable to continue to play the game by the rules, run the primary, run the secondary, and I'd take him through the scanner on the way to theatre.
Can I ask anyone, does nobody want to put a nasogastric tube because he has a gastrothorax?
He's got one in if you look at the X-ray.
Oh, does he? I can't see
Yep.
it.
You can see the 3 balls by the heart.
There, yeah.
That's as far as they could feed it.
So that means they
This
haven't.
was at the other hospital.
They haven't relieved his gastrothorax, his tension gastrothorax at the moment. So
It looks to me like they've tried. It looks to me like they've given it a red hot go.
But are there other ways of relieving that before you intubate him anyway? You could actually stick a needle through his chest to a wall to get into that stomach as well. If this is going to kill him when you start positive pressure ventilation.
Again, I think that a reasonable approach to this would be to pre-brief this. So you're in the operating room, you say one of two things is going to happen after we induce anesthesia and we start to ventilate him. Either he'll be okay or he just won't. If the anaesthetist isn't completely incompetent, they won't ventilate him at all until they've actually put a tube in the trachea. And so pre-oxygenation and all that anesthetic buggering around is going to be important, as will be a conversation with the surgical team to say, if it all falls to pieces,
exactly.
Can you please hit that with a needle? Another reason why a CT scan might be helpful, because it might tell you, am I going anterior, lateral, posterolateral, even something of that nature.
We're all chicken in this. I think we have a CT scanner. Okay, Tim, go on.
Thank you. So at the tertiary level 2, they were not willing to operate without checking the CT because they were worried about the leg and they wanted a CT angio. They also needed to assess for a TBI because although he was GCS 15, he was apparently 12 on scene when the ambulance got there. But he woke up. So we working on the concussion diagnosis. But again, this is at the other hospital. They discussed with us for takeover post-imaging, given the fact that he was in a stable condition and the fact that they did not have an ICU bed left at their hospital. So we had sort of agreed to accept him. We were hinting that they should just go ahead and operate, but they felt strongly that they wanted to exclude any vascular injury from the pelvis past the femur first. So they did the pan scan, and the brain CT showed a small left parietal acute subdural hematoma, not surgical intervention requiring. The spine was NAD. The chest, as expected, showed the large left-sided traumatic diaphragm rupture with herniation of stomach and splenic fracture of the colon into the left thoracic cavity. There was obviously a left-sided hemopneumothorax and a saccular outpouching of the descending thoracic aorta in keeping with a traumatic pseudoaneurysm. There was at that stage no contrast extravasation, so the clot thickens. In terms of the abdomen, the CT reported a grade 1 splenic laceration and a grade 3 liver laceration. And the distal third femur fracture was noted, mild comminution, but no vascular injury. So here's some selected pictures. There's the CT of the brain on the top showing the subsurgical subdural. It's quite small. The middle picture is the lung views, which shows the stomach in the chest, and the cardiac picture pushed across to the opposite side. And then the bottom left is the liver laceration, which was reported as a grade 3. And the next picture is the supposedly grade 1 spleen. We'll get back to that shortly. And then the two pictures, bottom right and extreme right, show the quite significant grade 3 aortic injury using the Society of Vascular Surgery grading from 1 to 4. So it's a confirmed pseudoaneurysm. So he was now transferred to us, which is the level 1 trauma center quaternary unit. We are about an hour's travel away from where this patient came from, and obviously relying on road transport because our helicopter service in my part of the world doesn't really exist in the state sector. So we just reassessed him once he arrived. He was still stable, and you'll see it's in inverted commas because I don't like the term stable. With mild respiratory distress, and the CT findings were noted. There's his index blood gas, heart rate, blood pressure, respiratory rate, etc. And yes, I think those are all acceptable numbers at this point in time, considering what he's been through. So, decision time for us. Do we just rush to emergency laparotomy with potential implication of damage control and then do something about the aorta later? What about the femur fracture? It's open fracture, so the orthopods, they like to wash these things out. And the TBI, as mentioned, is not for neurosurgical intervention, but 48 hours of neuroprotective ventilation. So the neurosurgeons wanted him intubated, normocapnic ventilation, etc. Happy to take comments. I see there's some in the chat. And yes, we had, I need to answer the comment, the nasogastric tube had been pushed down further and some air was returned, but most of that air appears to have been the splenic flexure of the colon.
So panelists or...
So with this in mind, which option are you going to chair? Delay vascular repair, proceed with damage control, surgery, and repair the diaphragm and whatever else might be necessary, but what about the compound femur?
I would say for the vascular injury, at least where I practice, I would probably go ahead with the laparotomy, place a chest tube on that left side, and I would usually consult vascular and probably try to wait at least 24 to 48 hours, make sure the head CT is stable because the patient will need to be heparinized, and then have them proceed with a TVAR if that's available.
TVAR is available in our institution, but not in the other institution. To respond to Steve's question in the chat, why didn't they proceed? Who knows? If they were unhappy to proceed and then transfer. I think it had to do with their anaesthetists not being guaranteed an ICU bed on site, so they weren't prepared to put to sleep. There's funny rules in this country of ours.
How many hours down the line did the patient arrive to your center?
About 5 or 6 hours post-injury.
Mm.
So way beyond the golden hour.
Mm. What kind of
Okay.
resuscitation? You didn't say anything about what kind of, did he require anything or nothing
Sorry, did he require anything of what?
of a resuscitation? Did
Uh, he was at no point hypotensive, or they put up ringers to keep vein open. He'd had less than 500 mils of ringers lactate when he got to us.
Would anyone give anything else?
No.
And he did get TXA.
Yeah, but is there would you, if you could choose freely between the different fluids, would you give anything other than ringers in a patient with that kind of head injury and sort of solid organ injuries?
Can
Would
I be
anyone-
the devil's advocate here and ask the opposite? Would anyone not give him anything?
Come on, panelists.
Sorry,
My-
I'm not sure I understood Marianne's question, and we are bouncing around a couple of topics here. Two big streams being discussed. Stream number one is current resuscitative profile. Stream number two is decision making. He's got three things which need fixing, and it's just a question of when we do which. To jump in a little bit on the resuscitation stream, I think to do absolutely nothing, which is really what this referring hospital did, is okay. Hopefully they had triggers that they could have pulled if he had deteriorated, although that's not necessarily the case. And to not give him robust intravenous fluid resuscitation and so on, I think that's absolutely fine. To continue to monitor his airway and give him some supplemental oxygen, I think all of that's absolutely fine. I certainly, and I think we can probably say that that's reasonable. In terms of the decision making as to where to go next, with the sort of anesthetic ICU retrievalist hat on, given that I'm allowed to say that because I do all three, the surgery that anything he's going to need is going to need him to be ventilated, at least in my institution. We wouldn't be doing TVARs or anything like that under local. And so I'm going to say to you, please get into that abdomen, sort the abdomen out, get the pressure off his lung, particularly as I'm going to be ventilating him, put the chest tube in that my colleague suggested. Thank you very much. Love the idea. Sort the femur out and wait it out for a couple of hours until we pull the trigger on the vascular test.
Diego, is that you wanting to say something or?
Oh, sorry, I activate the mic, but doesn't say nothing.
Okay.
I was going for the resuscitation question. I'm not sure what everyone else's practice is. I would say where I work now, especially for patients with traumatic brain injuries and with a lot of these other solid organ injuries, we would pretty routinely send a tag on those patients. And that would be the only other thing I may do for resuscitation is correct tag.
We do routine when we have ROTEM. We do routine ROTEMs on all polytrauma admissions pre-ICU. His was normal, which is why I didn't specifically include it.
And I think it's probably predictable that it's quite normal, but if you need anything at all, I would probably give plasma instead of giving crystalloids. If he needs
Sure. The crystalloid is started by EMS, and as I say, a total of 500 mils over 6 hours is not a huge amount. It was basically being used as TKVO. We did tell them that if he needs fluid to use plasma, and of course in South Africa we're very lucky, we have freeze-dried plasma, so it's on the shelf and we can get it mixed and administered within less than a minute. We don't have to wait for thawing and blood bank and all the rest. Okay, shall we move on? So we did the laparotomy as everybody suggested. Rapid splenectomy was done because I think I might have missed a slide. No. Rapid splenectomy was done because when they opened the so-called grade 1 spleen was actually an avulsed spleen. It was being tamponaded by the surrounding piece of colon, and as soon as the colon was reduced, the free-floating piece of spleen came up and everything started bleeding. So that was rapidly controlled. Spleen was taken out, vessels controlled. Diaphragm was drawn down with 2 swab holding forceps. The herniation was reduced, and a running Proline 1 suture was placed. I would have personally preferred a braided polyester, but all they had in theatre at the time was Proline. Chest tube was then placed under vision with irrigation of the chest prior to final diaphragm closure. Rest of the abdomen was examined. No other significant injury. The liver injury appeared to be an intraparenchymal injury rather than an open injury. And given the fact that the bleeding had controlled, there was no ischemic bowel, there was no deterioration of the blood gas, the decision was taken by the operating surgeon at the time to actually close the abdomen, and the anaesthetists were happy to allow the orthopedics guys to see these 2 slides got swapped around. So there was 300 mils of old blood, and the spleen was, as I said, a grade 5. And the femur was then washed out, and a primary nail was placed as early total care. And suffice to say, on the morning ward round the following day, there was a fair amount of quizzing from myself as head of department as to why they didn't do femur damage control. But in retrospect, it was a reasonable decision. Right. There's his. There's his
comments from the panel.
They're welcome to give comments, but there's his post-op day 1 in ICU chest X-ray with the nasogastric tube clearly going down now below the diaphragm, the left lung nicely expanded, but the pleural cap and wide mediastinum, or relatively wide mediastinum, still visible. Comments from the panel?
There's one question I missed. Did you say tell us something about the liver, or what happened with the liver?
The liver appeared to be an intraparenchymal hematoma with no capsular tear, so there was some bruising, but it wasn't bleeding.
Okay.
And the spleen is now out.
Yeah.
And throughout the operation, there was no need for resuscitation. It tolerated intubation without any problems. And
yeah, surprisingly enough, tolerated the intubation. Obviously ventilated much better once the bowel had been reduced into the abdominal cavity. It was a huge diaphragm rent. It was about 14 centimeters. It was one of our trauma fellows that was doing the case. She was on call.
Would you want, so for medication when you intubate that patient?
I presume that's our question for Simon.
Yeah, well.
So yeah, and this is one of those in a way tricky ones, and I have an enormous amount of sympathy for trauma experienced surgical people who have seen anesthetics poorly done and sometimes poorly timed. And I say it sincerely, I have sympathy for people who have watched patients suffer harm because of bad anesthetic decision making. And it might just be worth a quiet word to the anaesthetist, if this is something they don't do often, to say this is somebody who could really fall in a heap hemodynamically, cardiovascularly stable. The good old ketamine rocuronium double tap is probably advised here.
Yep.
And then also to say, almost as a follow-up stewardship statement, to say, please, can we track the blood gas? We have a requirement for physiological neuroprotection here. I'm not going to abandon you after the laparotomy is done. I'm going to stick around and make sure everything's still okay while the femur's getting sorted. Check back, because this may be anesthetic staff for whom this is unfamiliar territory. And so I just have those 2 things in the back of my mind, particularly for trauma-experienced surgical people.
Yeah, no, good point. And that's certainly what we do. We expect them to do blood gases in any major trauma case at least every 15 minutes, ideally, but ideally more often than that if the patient is in any way hemodynamically abnormal. And yes, I agree with you. Ketamine, rock, a little bit of fentanyl if you want, and try and keep it low on the inhalationals. Those are the inhalationals are a real problem. We had another patient recently where the other district hospital or regional hospital about 3 hours away had done a gunshot abdomen. They couldn't get the patient off inotropes. And so we said to them, "Where's the patient?" No, he said, "In anesthetic, in the theatre on an anesthetic machine." So we said, "What is he on?" "Oh, no, he's on an inhalational." Said, "Turn off the inhalationals." Within 15 minutes, he was off the tropes, and they could safely transfer him to us. Right, moving on. There's some post-op pictures of the very good handiwork done by our orthopedic surgeons. They make bones straight. Unfortunately, they forget there's a patient attached to the bones most of the time. I think that's kind of universal for orthopedic surgeons, but they're very good at what they do. And then about 3 days later, once he'd settled and was over his neuroprotection, and once our vascular surgeons had the opportunity to study the pictures and order the right size TEVAR, they did a TEVAR, and as you see in the last picture, the lung is nicely expanded, the diaphragm is nicely intact, the TEVAR is in position, and the widened mediastinum has disappeared. And this is 1 month later, his follow-up scan showing the TEVAR still nicely in position and no endo leaks or anything else around that, and good perfusion of his kidneys, etc. So he had a good outcome. He was with us in ICU for about 3-4 days after his procedures, and then was stepped down to the Bates Hospital for further rehab, and then seen by vascular in their clinic at 1 month. And that's kind of the summary of the outcome of the case. So it was day 7 in total when the TEVAR was done. So and when the femur and everything had been done initially. Yeah. Thank you very much.
Can I ask you a question?
You can ask this.
If you could have chosen, would you wait? Would you have done the TEVAR earlier than 7 days?
I certainly will not do a TEVAR. I think the evidence is fairly strong, and we've quoted it in the erratic paper that was recently published. The evidence is fairly strong that you should not be fixing them within the first 24 hours. The mortality is almost double, and the incidence of acute kidney injury almost quadrupled. But yes, the ideal is to fix them somewhere between day 3 and day 7, and obviously the earlier the better. In our environment, the challenge is access to the angio suite, because it doesn't belong to the vascular surgeons, it belongs to radiology. Getting the stent, because they have to size it and what have you, and then the reps have to arrange it, and then it has to get permission for purchase from the Department of Health. So that's why there's always these delays. But we generally get them done by about day 4 to day 7. And we've done in our institution, or in the time that I've been running the unit, we've done just over 30 of them for aortic injuries, most of which have come through my ICU. A couple of them didn't need ICU because they were delayed transfers to vascular directly.
I think our routine here is to do it earlier than that if there is no reason not to wait, and some of them are really, really, really bad, so that you really get sweaty when you see the aorta and you see this is not going to last long. And I don't think that many of those, this one doesn't look that bad, but some of them may be qualified to do it earlier, and they disappear in these studies. So I think it's just a word of caution in the worst ones, if possible, to do it earlier.
No, sure. I hear what you're saying.
Any other?
Tina, to ask a question back to you, if that's okay. It would be our practice to do the stent after the 48-hour progress CT brain. And if that looks clean, go ahead. Would that be the Norwegian practice as well?
Yes. And if there is no head injury, we would do it earlier than that.
Yeah.
So yes, no, they're definitely the same thing as waiting, as the sort of gradual start with trauma prophylaxis as well. I mean, they're aggressive, they're not waiting as long as they did before, but obviously you need to see that it's stable. It's not progressing.
There's lots of other people on the call. Any questions or comments from them?
Yeah, I was looking if there was more in the chat, but not really. I think it has been commented on. We'll try to.
General question about the diaphragm repair. I know that there's not great evidence, and I think it's probably just kind of based on everyone's practice. You said that you all did a single running repair.
Yeah,
is that
we teach, and based on experience over the years, and I must say I've done 30 or 40 big diaphragm repairs, and I've not had any one of them break down, and we follow them all up. So, but yeah, we do running repairs. I prefer using Ethibond, which is a braided polyester, but you can use a monofilament if you have to. And I've, touch wood, never had to put in any synthetic material to get the diaphragm together. If you're fixing them early, they come together with a bit of gentle taxis and some swab holding forceps, or Duvals if you don't have swab holdings.
I think there's also the studies or the evidence is also supporting you don't always have to use a non-resorbable. So I think it depends on what you have available, but not the short-term resorbable you should avoid probably. There's
Yeah.
comment in the chat. We do not have interventional radiology, so we resolve what is possible and wait for regulation to an acquired hospital. Thank you for your teachings. Yeah, so it's obviously a lot about resources and different settings and what is possible. But I think what Simon commented, I think having those discussions between the consultants available or those involved available in these patients, because they're really, really difficult. And it is going to be managed differently according to the resources. Okay, we are slightly
Thank you.
half hour. Thank you, Tim. So I'm going to leave it to Marianne to manage the next phase with.
I think our next presenter is Dr. Chow. Is he logged in yet?
He was. I saw him some time ago. Wait.
Not sure if he's having trouble connecting.
Seems to have dropped off. He was on as HC Chao, and I don't see that on there right now.
I did see his name on the list earlier before we started the first case. If he's not there now, then we have. So, Marianne, do you have...
Yeah, I just sent a message to Dr. Martis to see like if he has any news from him, heard anything as to why he's not being able to connect. Let me see if I got any messages on my phone about it.
And Tina, I realize this might sound like a remarkably stupid thing for me to say, but I'll say it anyway. In the absence of anybody else, what we could do is ask for people to just talk about a recent case. And
Yeah.
I'm happy to do something of that nature. I'll have to sort of dredge my memory banks a little bit, but I am left with the memories of a 6-year-old who we looked after fairly recently. That always gets one's it piques one's emotional interest, if nothing else, because there's always that emotional imperative when looking after children. And so, I'm sure that amongst us all, there is interesting cases to discuss. And so
I was thinking exactly the same. Maybe I was thinking to pull up a case, but I think that's easier to do because we have too short time to do that. So if you start out and then others can think.
Should we give Dr. Rao another minute or two?
We can start with your case while we wait, can't we? And then if you.
Yep, absolutely. So would it be helpful to start in the pre-hospital environment? Or in fact, what I'll do is I'll present it in such a way, it did start in the pre-hospital environment, but I'll present it in such a way as if the patient had presented to hospital. So this was a 6-year-old unseat belted front seat passenger. Yes, all of that badness. Unseat belted front seat passenger who was discovered in the footwell of the car and needed to be extricated. His heart rate on presentation to hospital, or well, bear with me, but his heart rate was approximately 150 beats per minute. He had a blood pressure of 85 systolic, a coma scale of, it was approximately 10, but his M score was 4. So his pediatric GCS. He was cool and peripherally shut down. The pre-hospital services had not been able to get any form of intravascular access, and he was accompanied by an incredibly distressed mother who had been the driver of the vehicle. And so I suppose that would be a reasonable place to start, to say, really, you may as well be at the roadside given how little has happened with this child, and ask for a general approach.
Anyone wants to comment?
I would say based on those vital signs, and especially knowing that it's a child, I would be very, very concerned because I think, as in my very brief experience of being an attending, the children that I have taken care of that have been very sick, by the time I feel like they are hypotensive and that tachycardic, I think that's very much so a sign of impending decompensation. So I think rapid access and calling for a weight-based massive transfusion protocol would be the very first thing that would be my priority in the trauma bay for sure.
Could I ask people's personal preferences in terms of access?
Well, in TAS, you can use the intravenous, but it's the same for me. I've never worked with childs. Is this something that all of us used to teach? But it seems that the preferable access will be an intravenous, and that means.
Yeah, I agree. An IO to start with, probably tibia. How old did you say the kid was? 6.
6. Yep, 6.
Yeah. So an IO, alternatively, if you can get a big line into one of the uninjured legs into the femoral, that would kind of be my second line. We like these sort of mini cordis lines in kids. If you can get them in, especially if you've got ultrasound guidance, we find that works even better than the intraosseous in the acute phase. And obviously the usual stuff, ABCs, FAST, etc.
Absolutely. So that's indeed the way resuscitation proceeded. We drilled an IO into the tibia on the left-hand side. There was no obvious external long bone injuries in this child. That caused a little bit of distress to the child to do it. Again, in keeping with the pediatric coma scale that we had, a massive transfusion protocol was called for, and that was commenced initially through the IO. We actually placed a subclavian 3-lumen 5.5 French gauge central line, just because it's what I had available, and it's reasonably good access and can allow you to sample blood and so on and so forth. In terms of the remainder of the survey, from the child's perspective, he had some fairly nasty facial injuries. We weren't able to examine the left eye. The left side of the face was swollen, probably indicating where he'd struck the dashboard in submarining underneath the car. Following the administration of 15 mils per kilo of blood and 15 mils per kilo of Hartmann's, essentially Hartmann's plasmolite solution, which was what we gave him because of, we believe, critical hypoperfusion prior to the blood arriving. His heart.
What's his
I beg your
whole
pardon?
What's his
No,
whole
it's packed cells. Unfortunately, the first run on our MTP is to get the packed cells in. And in fact, I'm just, embarrassed to tell you, we don't have a specific pediatric MTP. We pull an adult MTP trigger and accept that because it's so rare a situation that there's going to be blood wastage, which, yeah.
No, we
This had
understand.
caused Yeah, this had caused the child's heart rate to come down to approximately 120, and the blood pressure to improve to about 110 systolic. The coma scale was unchanged, so still withdrawing to pain. Eyes difficult to assess, but generously would give it a 2, probably not. And the V score was probably again about approximately a 2. So a relatively preserved M score, but E scores and V scores were poor. In terms of the remainder of the primary and secondary survey, good breath sounds, saturating well when we could get the sats to read properly, starting to pink up a little bit, and the venous blood gas showed a lactate which had come all the way down to about 1.9, so clearing lactate quite quickly.
What was the first one? What was the first
The first one, I can't remember, to be perfectly honest with you.
It was higher.
Yeah, it was higher, but it wasn't gross. It wasn't this like 9 or 10. It was maybe a 4 or something like that. I can't remember. It wasn't grossly elevated. And so we've now got a couple of teams involved and lots of shouting going on. And the shouting is prosecuting the cases for A, intubation, B, just get the child through the CT scanner so that we know what's going on, and C, get retrieval on the phone so that we can get this child to a place that's got pediatric neurosurgery, etc., etc., etc. So thoughts, please.
Does this mean that you are not allowed to do surgery for that brain injury where you are anyway? So the CT scan wouldn't have consequences for it?
I'm kind of making the case up as I go along a little bit, because actually the place I saw this child was at the roadside. We landed our helicopter on the road where the crash had occurred. And so I am kind of making this up a little bit. So let's assume that this is a level 2 system where there isn't pediatric surgery, where there isn't a lot of pediatric services, and no neurosurgeon would go near a child's head, if we could speculate that that's the kind of environment we're in.
So number one, you don't know yet if the patient needs the head opened. You've got a low Glasgow, but most kids will have diffuse axonal injury. A small percentage will require surgical intervention. So if you haven't scanned the head as a baseline, you're kind of grasping at straws. I would be inclined to say your GCS is around 8, and in kids we like to intubate when they go below 10. So I would support intubation and ventilation, not only from a airway protection, but also from a head injury point of view. Get normocapnic ventilation going. Quickly get if you're in a hospital that has a scanner, you don't have to do the rest of the body. Just quickly scan the head and see if there's something drainable. Because if there's nothing drainable and you've got the other facilities, and a pediatric surgeon can come in and there's something that needs done, then you've avoided an unnecessary further transfer. Transfers are always bad for patients, and particularly for kids, as I'm sure you're aware.
I'm sorry, did you mention the FAST on this patient?
Yes, FAST was negative, and fairly reliably. That kid FAST is just so beautifully easy. There's no problem with image acquisition. So FAST was obviously negative. Beautiful lung sliding both sides, and no compelling source of hemorrhage other than the face.
How long is the transfer to the hospital with facilities for whatever is wrong with the patient?
An hour and 15 minutes by air. And we have a facility. So let's say that the place where I'm presenting this is a place that has a CT scan. Could I just ask a quick question before I tell you what happened next?
Actually, I have a question. I have a question actually. You mentioned you started MPT with the same triggers as for an adult, but the FAST was negative, but you mentioned the patient was really tachycardic.
Yep.
Is that correct? So you
Yep.
couldn't find another source of bleeding?
I'm kind of keeping my cards close to my chest, if you'll accept that sort of English analogy. But he had really nasty facial injuries, really nasty facial injuries. and there was certainly a lot of blood around the head and neck,
Okay.
and in the mouth and so on and so forth.
Okay.
Could I just very quickly ask, who would have given this child tranexamic acid?
Yes.
Yeah, I gave him tranexamic acid for what it's worth. I just thought I'd ask the question.
I use
Simon,
1 gram in
Simon.
kids, 2 grams in adults.
Simon,
Tina.
you're saying that this kid is so he's responding to resuscitation, to moderate amount of resuscitation, and he has bad facial injuries. So you would obviously intubate him before you
Yes.
transfer him anywhere. I mean,
Yes.
there's no
Yes.
doubt. And he's a child. He's not going to be
Yes.
there. He's
Yeah.
mushed, and he's not going to be in a helicopter for an hour and a quarter to anywhere without being intubated. So if he's responding, and then the question is, depending on where you are, in Norway, that kid would not be taken. So they would be scared to death. If he was exsanguinating, he would go to any hospital with a trauma receiving capability, and then he would be transferred after damage control. This patient doesn't sound like a damage control patient. So this patient would go immediately by helicopter, and if the helicopter landed and got him on the streets, he would be transferred to a trauma center.
Yeah.
So it depends on the setup, I think. And he will get a CT scan when he arrives.
So obviously he was intubated and ventilated. And if I'm honest about exactly presenting this case without all of the fiddles, we drilled an IO first, used that to commence resuscitation, gave him drugs to assist intubation because he had blood all over his airway as well. He was intubated, and then while asleep, we put in the subclavian line, and we commenced blood product resuscitation from the blood product stores that we keep in our helicopter. And then our decision was, where do we go? Do we fly to the adult place, which is quite close, as compared to the pediatric place? And given the total negative fasts everywhere and good lung sliding and everything else like that, we chose to go to the pediatric place, just on balance of probabilities. His CT scan, he got pan scanned, obviously. He had a fairly larger than expected subdural hematoma, some ocular trauma that required addressing. He got an external ventricular drain, as just from a monitoring perspective. From that perspective, had a normal CT scan of his abdomen, except for a stomach that was relatively full with what was probably blood, maxillofacial injuries, and very little else. He spent 5 days intubated and ventilated, got some raised intracranial pressure day 1, day 2, and was later extubated, sent to the ward, doing well, according to his mum, when followed up. So thank you for being patient with me while I made things up as I went along, but had to import a patient from the pre-hospital environment into the in-hospital environment.
I think one, it's important because you have long distances, we're used to long distances, and lots of places don't have the facility. So that means bypassing is not a bad option quite often. I think sort of 1 hour and a quarter is less than he would have wasted in a hospital not knowing what to do with him and passing him by the CT scan before you can actually move him towards where he could actually get treatment. So I think it's a very valid thought process, and difficult patients, emotionally difficult patients for many.
Yeah, I think the time that we would probably advocate for the CT scan at base is if the helicopter still had to be dispatched to that hospital. So you've then got time to do the scan, and then at least you've got a bit more guidance. But here the helicopter was on scene.
Yeah, so that's a totally different setting. So we still have.
May I add one last little thing, if I
Sure.
may? And I suppose it's just from a systems perspective. His mum was obviously incredibly upset and distraught, refused any examination, treatment, and so on. And we only asked once because we were very busy with the treatment of her child. But we put her in one of the back seats of the helicopter, strapped her in, and ignored her until we'd handed over the child and done all of the other stuff that we needed to do. One of the ED docs at the receiving hospital then persuaded her to go across the road to the adult hospital, where she had had a pan scan and they diagnosed her sternal fracture, subsequently picked up her cardiac contusion and her grade 3 renal laceration as well. So just from a systems perspective, everybody else is obviously at risk too.
Any other comments? Anyone burning? Because I have a patient, if nobody else is burning, to present something. Have anyone thought of something that they really want to share?
No, I
Because
think
if
we
not,
could
I can
go
do.
ahead with a new case because I haven't have any word from Victor. I texted him, but I haven't received any messages. I don't know, maybe he had trouble connecting or had an emergency. I don't think he's going to be joining us today. So I think I can get an extra case.
Okay, very briefly. Again, this is along the lines you inspired me, Simon. So along the same line. So 15-year-old now, almost adult, at least running a motocross bike. And sort of crashing with someone and being taken. And this is in our trauma system, and it's not so far from Oslo. It's about sort of 45 minutes drive from the hospital that is closest to him. And he's being then fetched by an ambulance and bypassing. So this guy is really sick on scene. He has but he's completely awake. And he is, no, actually he's not, he wasn't 15, he was 12-year-old actually. And he was sick on scene, 160 pulse rate, and blood pressure around 90 systolic, abdominal pain, awake, even very polite to the nursing staff when he arrives in the closer hospital. So this is then, because the air ambulance is not there, and none of our ambulances would actually bypass a hospital with a trauma receiving capability to go to a trauma center that is 45 minutes further away with this kind of child, basically. So he is arriving in their emergency department, and so anyone wants to say. So when he arrives, he has a distended abdomen. He has a GCS of 15. As I said, he's very polite to the nursing staff and the whole trauma team. What do we do? They did not start. Well, they had got an IV line pre-hospital, and they had started giving him freeze-dried plasma on the way to the hospital.
Have they decompressed his stomach?
They have not. What do you mean by decompressed his stomach?
Nasogastric or something.
No.
So
So he has distended abdomen. So they haven't done any.
Generally distended, not just upper.
No. Generally distended.
So what resources do we have?
They have trauma team is waiting for him, obviously, and so they are doing their primary survey. They are starting his massive transfusion protocol. They give balanced resuscitation, only blood products. We don't allow our hospitals using crystalloids anymore in any of these patients when they are hemodynamically compromised. But he was really sick. They didn't call the trauma center initially, so they started resuscitation. Somehow they got his blood pressure up to 110 systolic, but he was still at 160 pulse rate. His blood gas came back with a lactate, an arterial lactate of 2.4 or something like that, so not very high either. And then he responded to the resuscitation, so they decided to take him to CT scan, which to me is a bit crazy. But it helped us when they called us after the CT scan, because it's much easier to understand then. So this is a patient that would never have been allowed to go to CT scan in our hospital. They took him to CT scan, and it's an impressive CT scan. It's the worst liver injury I have seen in 10 years. So the liver was divided in two with a massive extravasation. So divided into all the way to the IVC, and his abdomen was full of blood. I mean, really full of blood. So, but he was there with 110 systolic and 160 pulse rate and still awake.
Well,
and the air ambulance and the helicopter is there because they called actually to say we are sending this guy to you.
So I understand that they don't have angio facility or anything like that. So maybe,
I can say that the extravasation looks venous. It's so massive that he would be dead if it had been arterial.
well,
Okay.
once you intubate the patient, he's going to collapse. So if he had a chance to get transferred now, you should transfer now without intubating him. And if you want to intubate it and go to the OR,
If I tell you that, so I said, can you get the anesthetist together with you? The surgeon was calling. So at first my team leader called me and he said, if we get the phone call from that hospital, they want to send the patient. I said, ooh, who calls? And I said, so can I? So I called them, and then the surgeon was saying, oh, they want to send the patient. And I had seen the CT scan because it had been transferred. And I said, really, is he? So he's doing fine. He has 110 systolic, and his pulse rate 160. And I said, so what do you mean? Do you think this patient's going to be sent? And he said, yeah. And then yes, and the anesthetist was behind him. And I said, so I said, what happens every time you slow down your transfusion? How much blood has he got? Has he been given until now? So they had given 5 units of plasma and 4 units of red blood cells in this 12-year-old. And I said, so what happens when you change your bags? And he said, well, then he becomes gray, and then his GCS falls. And I said, you're not going to send that guy. Take him to the operating room now, and you pack that liver. And then we can talk. And you call me, and if you need advice during the operation, you call. So they took him to the operating room, and he was intubated, and they packed, and I was just crossing fingers that he would survive the operation. And they packed the liver, and then they were going to send him just after that. Then we get a new phone call. They said, now the patient is on the way into the helicopter. And then I get a new phone call 3 minutes later, and he said, well, he's a lot of blood is coming out on the drains of the VICC, and he has 70 systolic. And I said, you might have to do. I said, are you able to do anything else for this guy? This is like they have like 20 minutes a flight. What would you say? What would you say, Simon? Your flight.
Give me your whole blood bank
Huh?
and start the #1 engine. Give me your whole blood bank and start the #1 engine. We just need to get the hell out of there. Just go.
Exactly. And so I asked him, so do you have anything else? Do you think you can do it better? And he said, no. And I said, okay, send with blood products, and obviously there's an anesthetist on board the helicopter. So, and then I went to, obviously I was here, it was in the middle of the night, and we said, okay, so if he arrives now, he's either better because it has calmed down on the way, or he's going to be really much worse, and he's probably being overpacked anyway, so we probably have to take him to the OR anyway. There's no CT, so this guy arrives, and he was doing better. So he was obviously had an IVC compression, so he was obviously overpacked, but he was doing much better than what I had thought when he arrived. And I said, but he was not good enough to go anywhere from the emergency department. I said, okay, we'll just take him to the OR, and we'll open and see if there was blood on the drains. We'll see if it's that or if it's the IVC that's compressed. And if it's the IVC that's compressed, we need to take out some of the packs, at least, or repack. So they had something like 20 packs around that liver, and the IVC was completely compressed. And once you took out a few of them, he got much better immediately on the scope.
But he wasn't having any blood output through these drains, right?
No, actually, there was blood from on the drains, but not that much. And when we opened the VICC, there was no ongoing bleeding.
Yeah, so that's something that would be indicative that he was overpacked. Like if he's still crashing and he has no blood output, then it's probably because of compression.
But both those options would mandate us to go to the operating room and just do what's necessary. Yeah. So that's what we did, and then we got a new. So then we took him. So then he was unpacked again. So this is the really, really, really bad liver injury. And when would you take that patient back to unpack him? Because he was still struggling. I mean, there was not like a no. So there still was a partial IVC challenge, basically. And it was requiring some ongoing resuscitation, but not massive at all. And his lactates were clearing and so on. But he was, when would you take him back? This was, we
You
finished
mean
it.
when he first arrived or like after that?
No. After we had finished that partial unpacking, when would you take him back to pack him out completely?
Not before 48 hours.
Yeah. Yeah, next year. And it's attractive to run him through a CT again to
We did.
look for any blush you might have missed because
did.
I'm stating the blindingly obvious. Forgive me, it's the anaesthetist in me. I can't help but state the obvious. Just so that you're hitting anything arterial that you can, so that when you're taking him back as late as possible,
No,
with beautiful coags, that you've hit the arterial stuff too.
I would, yeah.
Oh, I was going to ask, would you all, for this patient after you pack them, I know you said it looked like it was mostly venous, but along those same lines, would you call IR and have them shoot a hepatic angiogram?
Well, no, actually I didn't, because we had our interventional radiologists are super service minded, and they looked at the first CT scan, and we went through everything of the CT scan from that other hospital. And then after we had partially unpacked, they were present when it was in the interventional radiology hybrid suite we have for trauma only. So they were there present, and so that they could do it. And with his groin was cleaned and everything, so they could go in if we needed it. We did not need it when that was a partial unpacking. And then we did a new CT scan. There was no blush whatsoever. And we left him, but he was struggling with partial IVC obstruction still because of the packing that was necessary in front of the liver. A small guy. So we ended up unpacking, and I have never waited longer than 36 hours, and I have never in 25 years had a rebleed after unpacking. But we spent 3 hours unpacking, because you really spend a long time soaking these and taking off millimeter by millimeter, and no bleeding whatsoever. We left drains and closed him.
I don't
And
think
we
there's
said-
like a magical cutoff time point for taking patient back. As soon
No.
as he shows
would-
any signs of getting his physiology better, I think it would be appropriate to take him back. We don't have to expect like
I think
magical
the
cutoff.
published evidence that comes largely from South Africa, from the Cape Town group, showed you're correct. 36 hours is probably safe, but anything before 36 hours, the rebleed rates are significant. After 36 to about 48 hours, you've got your window of opportunity, but then after 72 hours, the sepsis supervenes.
Those data are a little bit old compared to the resuscitation we are using now. So these patients are not rebleeding when we unpack, because they're better resuscitated from first stage. And the packs are so much easier to get off if you do it at 36 hours. And why I say 36 is because you're not going to do it the day you finish this in the middle of the night. You're not going to do it the next day. You're not going to do it the day after. It's going to be 36. But longer than that, no. And in this guy, I said, if he is deteriorating during that time because of the packing and still compressing, we might have to start to alleviate more of that packing before that. So this guy is now in ICU. He was unpacked, and I was waiting because part of his liver is devitalized. So, and I was waiting for maybe septic necrosis, and we've seen that twice over the last 20 years, where we had to do resection and we are now day 9 or 10, and we haven't yet shown any sign of that. But he is leaking bile as expected, and he's not going to get an ERCP because that's going to dry up. And he's doing fine.
No ERCPs before at least 14, maybe 21 days. There's good evidence that anything earlier is not helpful.
Yep. And even after that, we just prepare the parents that he's gonna leak bile for a long time, and most likely it's gonna dry up after 2 weeks. It's for the input. So I think at least we use the time, a little bit unconventional webinar this time. Thank you all for contributing, and hope to see you again soon on the same kind of webinar. Any last comments from any of the
Thanks, Tina, for asking me to present. It was a fun discussion.
Yeah.
Okay.
Thank you all
Thank you
for
very much, everybody.
participating.
Very much.
Thank you so much, everybody.
Thank
Bye-bye.
you.
Bye. See you.
See you. Bye bye.
Bye-bye.